I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome, welcome. Thank you to all of you who are able to join us this evening in our lung cancer living room. I'm Danielle Hicks, Chief Patient Officer, along with Bonnie Adario, who needs no introduction. She is a rock star survivor, co-founder, and board chair of the Go-To Foundation for Lung Cancer. The Living Room Support and Education Series was created specifically for you in mind, and you being the patient, the caregiver, anyone who has a connection to this disease, and covers monthly topics varying across the landscape. This evening, we have Dr. Narjust Duma from the University of Wisconsin Carbone Cancer Center joining us to talk taboos, lung cancer, women, and sexual health. We believe wholeheartedly that educated and empowered patients do better, and we're excited about the conversation tonight. So thank you again for joining us. Before we get started and jump in, because we've got an hour to cover quite a bit, or only an hour to cover quite a bit, I'd like Dr. Duma to tell us a little bit about herself and why she chose lung cancer as an area of focus. Dr. Duma?
So thank you, everyone. I'm extremely happy to be here. I think I couldn't be here without my patients and patient advocates that adopted me when I was very early in my career. So I'm the daughter of surgeons, so it was expected for me to become a surgeon. But I remember rotating through the oncology floors, and I fell in love with a patient. She had lung cancer, and I developed a relationship with her. She didn't have any family, and then finally, the awaited rotation for surgery came around. You know, the expectations were so high. You're the daughter of two surgeons, but I found myself wanting to go back to that patient with lung cancer and like being eager that all the cases in the OR would be done so I can go back to her. So I told my dad, I was like, I'm not going to be a surgeon. I'm going to be a oncologist. And he's like, oh yeah, you're going to pass that phase. Well, we are many years now. And I can tell you that there's nothing else that fills my cup more than talking to my patients. Today, I was feeling tired and disappointed about many things. And I just talked to my patients, and it was like a new blind came down. Nothing else matters. And they're just family, you know, to telemedicine and getting to know them, and they're getting to know me in a different level. And I see that as a silver lining of the pandemic, is that now I can see the cats, I can see the dogs. My patients, I have one cat, which I got in the middle of the pandemic. So my patients are like, how's the cat doing? Show me the cat. And then I'm with my computer chasing the cat in my house so they can see it. So I think is a lot of times people say there's a calling, and I couldn't say that it was not a calling for me because I was drawn a different pathway, and lung cancer called me. I don't think we can
Danielle,
hear you.
open your microphone.
Sorry, guys. I think, thank you so much for sharing that. I think one of the things that is going to come through loud and clear throughout tonight's program. For those watching live and those who will come back and watch post live later, is your passion and your commitment to this disease and to the patients that you care for. So I know the first time you and I spoke, I fell in love with you right away, and I'm sure the folks watching will too. And I don't know, before we jump in, if our rock star, also survivor, wants to chime in with a few words before we get started.
Well, it's so I'm so happy to meet you, Narjust. I've heard so much about you and your passion, and I think this is our first all girls living room. So I equal your passion in the women's voice and all of the things that we can do together. So I'm excited. Let's just get going. I want to hear more from you. Everybody's tired of hearing from me.
Well, I think we couldn't be here without you, Bunny.
So I'm going to start, and I'm going to jump in. I mentioned at the beginning of the meeting that we're going to be talking taboos, and I think when we think taboos, particularly around lung cancer, some of them are tied, or some of the conversation is tied to shame, blame, stigma, some of the things that we don't always like to talk about, and people who are diagnosed feeling like they have to sort of hide in the shadows. So I thought maybe we could start around the increased incidence in women in particular who have been diagnosed with lung cancer, and how we think maybe that sort of came to be in some of the influences.
So, as to the people who are listening, I specialize in women with lung cancer because there are many unique needs to our women. Disease can be different, and survivorship and stigma is very strong for women. I have seen it firsthand, in which my patients don't disclose the diagnosis to their family just because of the fear of the stigma. And I have cry as I see obituaries in which they say the patient had bone cancer or brain cancer, when in fact the lung cancer has metastasized to that organ. But the family and the patient feel more comfortable with that. And I think carrying the burden of that is enough, the disease itself. And then you also have the fear of not being able to share it with your family or friends. So I think so let's talk about the incidence of lung cancer in women. First, the incidence of lung cancer in women increased as the smoking started in women. But one of the things I talk to my women in my clinic is that the past is the past, and there are different habits and different situations. But the incidence of women smoking in the United States was actually the result of many marketing campaigns. It was just not by chance. It happened, it was a precipitated move in which the tobacco companies created campaigns that started in the 30s and they went all the way to the 70s, even the 80s, in which smoking was associated with independence. It was associated with weight loss. There are campaigns of certain tobacco companies in which the slogan is like, if you want to get rid of a few pounds, smoke this type of cigarette. And the most important thing, harmful thing, is that smoking was associated with the woman that was joining the workforce, the woman that was divorcing, which it was less common in the 50s and 60s. And that was something that our women needed. We were asking for our independence, trying to join the workforce in a very hostile environment. And, it was the campaigns were targeted for these women to feel like, oh, I'm independent, and that associates with smoking and in an office now. And that actually generated these stereotypes that were associated with smoking. And I think I told my women that this was on purpose. It wasn't just by chance. It was repeatedly said that you will lose weight through smoking. And that's a very important subject for women. Like, and a very honest person. So I'm always trying to lose a pound here and there. So that's no secret. So that secondary of that was an increase of 300% all the smoking rates in women.
And it was also considered to be sexy,
Yep.
right? And I think women thought they were more attractive to their boyfriend or their husband or whomever because they were so sophisticated and smoking.
Yeah, and the outfits were, determined. They were suits. And I want to tell a quick story, and I think I told Danielle this story. So I have a patient that she was the first divorcee in her family ever. And she was new and she was secretary, and then she found that the only way that she felt any support was going out and smoking with other divorcees, because otherwise she was going through this very non-supportive environment in which she was seen as a failure as a woman because she got divorced or an abusive relationship. So she told me that the only moment I could speak my feelings was when I was out for a smoke with the other people from my work. So I'm like, that is a coping mechanism. Like, you needed therapy. Therapy wasn't a thing back then, and so it was your way of coping.
And I think one of the things that we talked about too, if you could talk a little bit about, was physicians actually recommending or prescribing cigarettes for certain things like hysteria and whatnot. That just kind of blows my mind to think because the time we're talking about wasn't that long ago. At least I don't think it was. My kids probably think it was, in the dark ages. But that was something that actually happened.
Yes, so there is, a lot of aspects of gender bias associated with these smoking behaviors. But yes, so melancholia, which is the old name for depression in the 40s and 50s, and hysteria, which is anxiety, and sometimes it wasn't even anxiety. And there were, in certain parts of the country, the husband who asked for the cigarette prescription or the benzos prescription for the wife to help with the nerves. And yeah, they were prescribed. And there are pictures that you can Google in which there are cigarettes that were sponsored by hospitals. So,
And
but
all of the, sorry,
go ahead.
Narjust, I'm sorry. I was going to say all of these things kind of led up to obviously what we know now as pretty severe addiction, right? And people not being able to stop smoking even when we did know how bad it was for you.
Yes, and there's also data that shows that, and this is something part of my research, that smoking sensation is very different for women than men. And we keep treating our women with a smoking sensation the way we treat men. And there is several studies that shows that women have a more emotional attachment to the cigarette and less of a physiologic attachment. So we try to put our women to smoking cessation, just give them nicotine supplementation, and they have lower cessation rates. It's because we are not addressing the need. So there's more emotional attachment, and there's also a worry about weight gain. I can tell you, out of one man that tells me he's worried about weight gain with the quit smoking, there are 5 women that worry about it. And it's again all that propaganda and the fact that, if you gain weight as a woman, you lose value. So there are different ways, and data have proven, in which women see a smoking cessation compared to men. And offering tailored treatments and to listen to our patients' concerns about smoking cessation can come a long way for a woman compared to just giving them the nicotine supplementation.
Interesting. It's really, really, really interesting. So one of the things, and we've talked a little bit about smoking and the increased, incidence correlating back to some of this direct marketing and propaganda. What about never smokers and younger women? And by younger, I mean, under the age of 39. What are we seeing there?
So it's very important that you mentioned that. So in 2018, there was a large manuscript of paper published in the New England Journal of Medicine. So to the people that don't know, the New England Journal of Medicine is like the holy grail of medicine. If you publish there, like New York, if you make it there, you can make it anywhere. So Dr. Jamal and collaborators reported that for the first time in history, women between 30 and 44, particularly 30 to 39, were having higher incidence of lung cancer than men for the first time in history, there are more young women with lung cancer than men. And to me, is alarming, and it's something that we have to do something about it. We cannot ignore the fact that our women are being diagnosed with lung cancer and they're dying of this disease, and appears there's only a subgroup of people that worry about this issue. So that shows that even when accounting for smoking behaviors, because always we know that there's higher smoking in men than women, but even when accounting for smoking behaviors, there's high incidence of young women with lung cancer as per today. And having a clinic that specializes in young women with lung cancer, I can tell you that every day there's sometimes a younger patient that we ever expected. And treating patients are in their 20s, and some of them actually express frustration. It's like, I have this disease, and there is a few people that hear my voice, but when I'm trying to scream louder, I don't hear anybody listening. And I think that's the importance of the Go-To Foundation and other organizations that are giving voices to patients.
I think I know you're aware of this, and a lot of the folks watching are also aware of this, and some of the support services that we provide. And I've been answering the phone for a long time from people that are in this category, men and women alike. But to your point, more women, at least anecdotally from my perspective. And um, I know that Bonnie has a lot to say about this, given some of the work done several years back. I think 2008 is when it first started. Maybe I'm wrong about that, I'm not sure. But I'll let her talk about it. And really kind of looking at this group, this sort of cohort or group of young patients being diagnosed. So do you want to talk a little bit about that? I'm going to mute.
Sure. And our results from a study trial that we did was over 80% of these young people under 40 years old really mostly never smoked. But what they did do is they were very, very they exercised a lot. They were runners. They were spinners. They were doing marathons. They were doing all kinds of things, and they 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 appeared to be the complete antithesis of what you might think of when you think of somebody that has lung cancer. And we're actually getting ready to launch an epidemiology study about this with USC and University of David Carbone's place out there. Yeah, to find out why. And we're seeing that there's a huge issue in hormones and hormone activity from maybe all of the extreme exercise versus what I might be doing or Danielle might be doing. And the findings are showing very interesting results.
I think I'm excited about the epidemiology study to really kind of take that
Yeah.
deeper dive look into
Yep.
this young subset of the population. And I know,
Yeah.
this had started with us with a young lady named Jill Costello, who was diagnosed while she was in college. She was a coxswain on the crew team at Berkeley. And, we didn't know a whole lot about biomarkers back then. We knew of a few. Some were most. I think EGFR was the only one that had an FDA-approved target. And ALK, I think, was still in trials. I don't even know if anyway, it's neither here nor there. But unfortunately, she wound up passing away right after she graduated, and it sort of sparked this fire. I know under Bonnie's behind, and folks here, at the foundation and over at our sister organization, Alchemy, and really is what kind of spearheaded this work. And it thrills me beyond belief to know that you, Dr. Duma, are continuing that work, looking at this subset of patients.
Exactly. And our epidemiology is going to cover, because the amount of patients we had in the first study/trial, wasn't a huge amount. This is going to be a lot more in the epi study, and we had some epidemiologists that wrote the questionnaires, and it will involve smoking, and it will involve other behavioral issues. But it's going to be really interesting. When little Jill died, to Danielle's point, I was determined to prove that there was a young lung cancer, and I called a reporter in Washington, not Washington, in New York, asking, would you do a story? Jill had a little friend that graduated with her from Berkeley, um, who wanted to run across the United States to raise awareness for young lung cancer. So I called the reporter and asked her if she would be interested in writing a story about these young people. And she said, "Give me data." I called every physician and researcher I knew in the entire United States, and some in a few other countries, and asked about young lung cancer. Every single one of them said there is no young lung cancer. And I said, "Oh yes, there is." And I'm hell bent on proving it. So we did with this study the genomics of young lung, and we're going to gather more information, and we're going to also draw blood. We're going to look for other specimens and do beyond genomic profiling, finding out all we can about this cohort. But it's primarily young girls. So more to come,
Yeah.
more to follow.
Yeah, and I think
And
we're going to talk a little bit about some links there as well. Dr. Doom, I didn't mean to cut you off. Please.
yeah, that's I'm here to support your observation, Bonnie. The majority of the patients I see that are younger are women, and many of them are athletes. Because I often found myself to schedule things around marathons, or I have a patient that did an Ironman last year. And that's a challenge about diagnosing these just young women, is because they don't fit the box of the patient with lung cancer. So there's so many delays in their diagnosis. And something that I sell in everything I do is when you remove the smoking curtain, you remember the iron curtain from the Cold War, so I call it the smoking
Exactly.
curtain. When you remove that, lung cancer is a disease of women, because I think I have some echo.
That's wonderful.
um,
Yeah.
I think because 2/3 of the patients that I know never smokers are women with lung cancer. So we have to see this disease as a disease of women. We need to do that because we are delaying diagnosis. And now with the current pandemic, the things I'm seeing are worse than before. So they already delay the cycles of antibiotics, the albuterol, and the mammograms that are done for somebody with a cough, they're added on to the pandemic. Knowing that this is a disease of women, we help to decrease the time, because many of them don't qualify for lung cancer screening, because many of them never smoke, many of them have less than 30 pack year history. And it breaks my heart, and I apologize so many times. I'm so sorry nobody diagnosed you before. I'm sorry you have to tell me your story of 6 months
Right.
trying to get something done. And I think it's just our own bias that we see the disease as disease of middle-aged white men.
Right, exactly. And for these girls, very interestingly, they take hormones much earlier now than they ever did before. Seventh and eighth grade, and they're taking the hormones, birth control, much later, till they're in their 30s. It's unheard of to take hormones for that long of a period. And then they are having trouble, getting pregnant and having babies and all of those things. And so IVF enters. They're taking, big, powerful bouts of hormones to try to get pregnant. And we've got so many young girls that are in that exact place, and horrified that somehow they caused this themselves, and they really didn't. They did not cause anything themselves. This is environmental, really honestly no different than smoking. These are behavioral things that, get us backed into a corner for whatever reason. But the bottom line, and I know you believe this too, anyone can get lung cancer, and we have to stop the stigmas. We have to help. We have to help all lung cancer patients. And now I think because of these young people, that's gonna be a big help in reducing stigma. But we have a lot of work to do. We still have a lot of work to
Um, it's a lot of information, and the passion is clearly coming through in the conversation. One of the things I want to talk about, because I know a patient personally who um, was affected or diagnosed with lung cancer, stage 4, actually at a very young age, and knock on all the wood in the room, has been NED for 8 years now, 6 or 8 years. And one of the things that her doctor was very proactive about upon her diagnosis was fertility preservation. So can we talk a little bit about with whom and when that conversation should be happening and makes between the healthcare professional and the patient diagnosed?
I think that's extremely important. First, I think it's important to mention that having a stage 4 diagnosis does not mean you cannot have a fertility goal. Let's be clear about that. Women can be anything they want, and if one of their goals is to be mother, a diagnosis of stage 4 should not take away that for nobody. So I think one of the fears of my patients is like, oh, I have the honor to be alive for lung cancer, I shouldn't ask more. So it's our duty as oncologists to bring that up at the time of diagnosis. There's so many things in our patients' heads. So I have a little template in my notes that reminds me about fertility. And I even ask sometimes my patients, and they're like, Dr. Duma, I'm 67. I'm like, but I just want to make sure, because there's different ways of mothering. Because it's better that they told me no than no asking. And it's okay to ask your doctor to delay treatment until fertility preservation takes place. And this is for women and men. For men, it tends to be easier to collect and bank sperm. For women, it takes some preparation to do that. And some data is not very strong. But it's important that for all patients, the options are provided. Because there is no data, there is no clear data about the effects of EGFR inhibitors, ALK inhibitors, ROS inhibitors, NTRK, less NTRK, obviously, RED. There's no data about the effects on the fetuses. There is no data about the effects in the ovaries. And as women, we're born with our eggs. Whatever we get exposed to, our eggs are going to get exposed to. We don't make eggs as we leave. So that's one important aspect. And immunotherapy, I'm working with Dr. Lambertini for Italy to understand the role of these agents. And Bonnie and Danielle, something that really worries me and is that these agents are moving to the adjuvant setting, but we have no data on fertility and no data on safety in fetuses. So now we know osimertinib is here to stay. Who are the majority of the patients that benefit for osimertinib in the adjuvant setting? Young women. 3/4 to 2/3 of the patients in the trial were young women. So we are putting these women in osimertinib for 3 years, but we have no idea what this pill does for fertility. And now we hate that we're going to be where breast cancer was years ago, and which we're like, oh, shoot, we forgot about fertility. Now we need to like find out. So, and I would like to hear your opinions about how these agents are moving to the adjuvant setting and how we have no data, because immunotherapy is also moving to the adjuvant setting. That means before surgery or after surgery.
And I think we have to make it standard of care for this discussion to take place with the physician and the patient before they start any kind of therapy. So they're part of the decision making process, because the real crime here is that the toxicity starts flowing, and they may get to a point where they're doing okay at the end, at least for some time, and now they can't necessarily do the work they need to do to have a baby. And I love what you said. We can't take that option away from them. We have to make sure they have that option at all points. So, we would love to work with you on that. Absolutely.
Yeah, and I think it's important. There are definitely two sides to this, particularly right now because we're closer there in the adjuvant setting than we are in the neoadjuvant setting when we're looking at this targeted therapy thing, right? And I think um, the the shared decision making and the conversation between physician and patient absolutely has to happen. I think when you're looking at weighing odds and talking about goals of care and all of that, I think the fertility piece definitely has to come into it. The patient that my family is very close with that had this fertility preservation conversation with her physician. She had they preserved their embryos. She had a surrogate, and she's got two beautiful, twin daughters who are running around like absolute crazy people now, right? And I think, yeah, and I think that's part of the conversation when we're talking about potential effects, on the fetus after you've done all of this kind of stuff. So, I mean, I think it's exciting what's happening in this early space when you look at the data of recurrence post surgery for a lot of these early stage patients. That number's too high, way too high, right? For multiple reasons. And I think that's a whole separate living room. We could talk about that, right? But I think really what it boils down to is that risk reward and having that conversation and balancing out and weighing what that looks like. So,
Well,
And there are many.
I'm
Go
sorry.
ahead, Bunny.
I can say that when somebody hears you have cancer, regardless of what kind of cancer it is, they're somewhat paralyzed for a certain amount of time while they're going through talking about, what the various options are and things like that. And one of the options we need to discuss is is babies, and storing eggs, and doing that, which all of these young girls would have been grateful to have, and haven't received that. So it should be part of the options that they get to discuss upon diagnosis.
And we know that, these patients, even with osimertinib, they get chemo, right? Some patients get chemo, and we know what happened to the ovaries with chemo. There's no data, it's a lot of data what happens to them. Some of them recover ovarian function. And I think that's tied with fertility. We need to talk to these women about some of these unique women's side effects that we experience. Because I don't want them to be surprised. So I talk about hair dryness because that's important to like vaginal dryness. But before we move to that area, I just want to make sure that the people are with us know that there are many options for fertility preservation. That is, in that the science has advanced so much, you don't have to commit to getting pregnant, or you don't have to commit to having a relationship at that time, because that happens to some of my women. Some of my women are like, I just want to preserve my embryos. You never know when Mr. Charming will come around, and you would be surprised. Sometimes they come around, and then we have the embryos. We have the eggs before, and I can tell you, sometimes are more scared about getting these retrievals because it takes a lot of like work to get the retrievals for my patients, or removing the ovary. And I think I told Danielle when we were chatting initially, I was in my car waiting for the call from the fertility doctor to tell me that we have enough eggs, and my patient popped the aletinib in the parking lot of the fertility clinic after we
Yeah,
corroborate everything was okay. She carried the bottle with her into Dr. Duma and taking it now. I'm like, yes, the eggs are safe.
there you
Take
go.
your pill.
There you go. Yeah, there you go. Yeah, exactly.
This
Exactly. Yep. Yep.
You're muted.
Danielle, I think you're.
Sorry, I did it again. For those of you watching, the technical difficulty is coming um, from my mom. As most of you know, she is my mom, and I being in the same room. So I have to mute myself when she's talking, and inevitably I'm forgetting to unmute. So my
She would have
apologies.
loved to have been able to do that when she lived at home.
To mute you, yes. But before we move on into some of the other things that we're going to talk about tonight, I think one of the things that you and I discussed, Dr. Duma, was concerns patients might have about other screenings or just regular routine healthcare checks that women do annually, particularly, at a certain age, whether it's, mammograms or whatever. What do you tell your patients about that are going through, treatment for their lung cancer, about how to manage some of those other types of general wellness appointments?
I think it depends on the stage of the disease. I think it's very important. Patients with early stage, it means they got surgery and adjuvant chemo and that they don't receive more therapy. They should continue with their screening because just having chemotherapy poses a risk for other cancers. I think it's important to know that having chemotherapy will put you at risk for further cancers, not only leukemia, but any other types of cancer. So those people, the patients should follow the recommendations. So lung cancer is not exclusive for getting not getting other cancers in the future, and we need to make sure that our women that already at risk for secondary cancers are following the recommendations. For patients that unfortunately are dealing with a stage 4 disease, it means disease that has spread to other organs. I have a very honest conversations with them. Lung cancer in some of these cases is a fatal disease, and we want to make sure that we are not adding unnecessary procedures to them. So I have an honest conversation with them. It's like, what happens if we diagnose you with breast cancer? We now have a bigger monster in the room that we need to take care of. Because there's such an embedded worry about breast cancer and mammograms, some of my women told me they feel more peace getting their mammograms done despite having metastatic lung cancer. And for me, the goal is that my patients have the most peace possible. So if they feel comfortable and knowing that they're dealing with a fatal disease, they feel comfortable getting their mammograms, we go ahead. But I usually not 100% in favor because we are dealing with a big issue. And I don't want them to be spending more time in the doctor's office when they can go, apple picking or whatever people do in the fall. But I think that's the goal, that they spend the more time outside of the hospital, the better. That's my number goal to them. And I often call them and say, what are you doing? No, go out, do something. But if they feel like it, obviously. So I think for early stage, they need to follow the same recommendations and even a closer follow-up because they're a higher risk for having other secondary cancers. For patients that have a stage 4, I think it's good to have an honest conversation with your oncologist, because we're dealing with we're fighting a big monster when we're dealing with lung cancer. Many patients can live years now with targeted therapy, but sometimes adding a burden of finding a calcified nodule on the breast goes you into this black hole that you may have unnecessary procedures, but you still have to worry more about the lung cancer. And I have to tell you that one of my patients found a mass on her breast, and we found it, and it was lung cancer. So lung cancer, in fact, can metastasize to the breast too. And rare occasions where it can happen. So having an honest conversation with the doctor is the most important, and what will give you peace. And we keep you doing the things you enjoy.
So one of the I think that's fantastic, and I think it's such an important message. But I think one of the things I want to ask you about, because again, knowing patients, multiple patients actually around the world, that this has happened to, I'm wondering if there is any data or information out there linking or correlating data between lung cancer and a second primary breast cancer. I tend to know, regardless of age, women who have had 2 separate primaries, one in the breast and one in the lung.
So what we see more often is the initial diagnosis of breast cancer, followed by a secondary diagnosis of lung cancer. And I have 5, 6 women with that in my clinic, and these patients are never smokers. So a very important part of breast cancer treatment is chest radiation. Includes axillary radiation, axillary to the breast. And that increases significantly the chances of developing lung cancer. So these women develop secondary lung cancer after that treatment. And also many of these women receive chemotherapy. So they have anthracyclines, which is a type of chemotherapy that we know produces secondary cancers. So that puts them at risk for that. So the 2 factors put them at risk, the radiation and the chemotherapy. And to the point of Bonnie, there's some data that was for a former colleague at Mayo Clinic that she presented. There is also a hormonal aspect that we don't really understand well, because these women also go, if they have hormonal receptor positive, they go on hormonal therapy for 10 years now. Before it used to be 5, now it's 10 years.
Right.
So we are, affecting the hormonal status of these women, and that we know we have estrogen receptors in the lung. There are not that many testosterone receptors.
Right.
So there is a relationship between that. And Dr. Jill at the University of Minnesota has studied this for a while. And just to, make it more interested, before at the beginning of EGFR therapy, there were studies about fulvestrant, which is a hormonal suppressing therapy for patients with lung cancer.
Okay, interesting. Interesting. And exercise itself can also have an effect on your hormones. And for men and women, have a huge effect to the point where sometimes women stop menstruating. So then they move on to the point in their life where they're looking to have a baby, and now they've been doing all of this other stuff for so long. Now they have to do IVF, in vitro, and that in itself is the springboard, for the cancer to show up.
And we know
These are
that because
things we
many
have-
Olympians
Right.
don't have their periods.
Yeah, exactly. Yeah.
In a different way, but similarly, and I'm just thinking out loud right now, but to some of what we talked about earlier in this, and women and image, and this, when you look at in the US, and I'm assuming around the world, this this need women have to look a certain way, and to be at the gym this many days a week, and you know what I mean. I'm curious as to whether or not, and we'll see, right? We'll see what impact that may have. We have a question from online that I wanted to ask before we jump forward, but the question is, if you have nodules in your lungs and you start taking hormone replacement, is there a higher risk of the nodules growing due to that hormone replacement?
So there is no accurate, they are going to say, yes, they're going to grow. Well, if we learn about the Women's Initiative study, which is the study that evaluated hormonal replacement therapy has been associated with many other, some cancers, right? Of course, breast cancer and endometrial cancer, but there has been some association there. The question is, what is the origin of the nodules? If the nodules are calcium, they're not expecting to grow. They won't be affected by hormone. But if the nodule to start in was already a malignancy, then they will grow, but it's unclear the relationship with the hormone. So let me be straightforward. There is no clear data if they will make it growth or no. But there's some indirect data. There's hormonal aspects associated with lung cancer, because the Women Initiative study shows similar to that, what Bonnie has mentioned about young women that had high exercise, or they're very athletic to a point that they don't get their periods. And we also have seen this in these breast cancer survivors. So there is a relationship, but I don't have the exact answer yet. But I'm dedicating the years I have left to find exactly link, because it's fair that we know.
Yeah. That's great.
It's huge. And these things exist before. My mom My mom knew nothing about taking a birth control pill or anything. You know, they used the good old fashioned way of not having any sex at all. Um, but you know, there's so much out there that these are different times, different worlds, different everything. And hence the epidemiology study we're doing, which is going to be asking all of these questions, asking your exercise habits. It's actually asking about your, you know, your hormones and, you know, various different things you may have taken throughout your life and all of those things. So hopefully we'll get some answers that will lead us to do some really, really good research um, to come up with solutions.
Dr. Duma is working very closely with Go2On through our lung cancer registry. We're really proud of it because, to the best of our knowledge, nobody has really looked at this before, at least in lung cancer patients. And that's sexual health and women. And again, talking about some of those taboo things, it's not something that a physician normally is talking to their patients about or asking their patients about, unless, of course, the patient is brave enough to come and have, you know, start the conversation with them. So can we talk a little bit about the Shawl study and why we think it's what it's intended to do and why we think it's important?
I think the take-home message is that sexual health equals quality of life. A sexual health in women is a very essential part of our identity and our well-being. Unfortunately, there's a lot of taboo about women's sexuality. And that dates millennium back. It's not from the last century. Dates millennium back. We didn't start dissecting female genitalia until, I don't know, less than 100 years ago. And we have been dissecting bodies for thousands of years. So that is a taboo about it. But it's important because sexual health is equally our life. And our patients are living longer. So are we expecting our positive patients that live a median of 6.4 years to go 6.4 years without sex? That's just unrealistic. Because we know that sexual health, if you have sexual dysfunction, you have worsening pain, you're more associated with depression, it's more associated with problems in your relationship. So having a focus on sexual health means we give focus to things beyond their lung cancer. Yes, they have lung cancer, but that doesn't define our patients. It doesn't. It's something that happens to our patients. We deal with it, but we also don't forget what makes it an individual. And that's sexual health to me.
Exactly. Absolutely.
Yeah.
And how they feel about themselves. You know, your life is over till it's over. And there's, yeah, love it.
And everybody's feeling, everybody has their own feelings about this, right? And it is such a personal thing. And I think is one of the reasons it hasn't really been talked about. And I think, you know, with this study through the lung cancer registry, we're really hoping to be able to come up with some thematics or some, you know, something that we can then go out and share with the world to help. So I guess sort of make this part of the conversation as opposed to something that is kind of, you know, hidden behind the curtain.
And you know, I think a lot of this could actually help eliminate this stigma. You know, I mean, what we're doing is associating this with breast cancer and other female cancers, and all of a sudden, it makes us human rather than um, you know. I think it'll do a lot in that direction.
And, you know, I came to this idea to Dr. Moore for Going Through Foundation. And I remember telling her, this is happening to my patients. We need to do an intervention. And she and I were like, but there is no data. How are we going to do an intervention? Like, and then I went in this literature reviewing studies for 1999, which there's still good data for 1999, but this is 20 years ago. in which there's a very limited handful of women that were included in the study. And they're only mentioning physiologic aspects of sexual health. And sexual health in women is very complex. We know that it's more complex compared to men. So in my patients with lung cancer, the issues of sexual dysfunction go from vaginal dryness due to osimertinib to body image because they lost their hair due to Abraxane. So I think the SHOW study will allow us to understand what is the real issue. And then in conjunction with the GoTo Foundation, we're not going to let this study just be and be a publication that we put in our CV and then we're happy. The goal is to make an intervention that all women with lung cancer recover their sexual health and that they feel empowered to talk with the doctors. As oncologists, we don't have the training. I have been trained by sexual counselors. I keep asking questions. I keep learning. And I thought one of my patients had a pelvic floor dysfunction because she had 8 kids. And I was like, okay, this is a new one. Let's figure out how we're going to fix it. Because I'm not here to get the answers, but I'm here to refer you to the right therapist. Now she is doing much better. Her relationship with her husband is better. But if you don't address the issue, we know the data is not going to get better over time. Sexual dysfunction in patients with lung cancer, if it's not addressed, it only gets worse. So,
Right. And we need to give them their life back.
yes.
Yeah.
And a good
and I
sexual
think,
life.
Exactly.
yes, yeah.
Well, and that leads to other good parts of living your life. More romance, more talking with your husband, more of everything.
Connectivity, I think, is important. And I think this points back to how important it is that patients watching consider joining the registry and becoming a part of this study, because without the data, we can't help, all of the women out there right now sort of suffering in silence, right? We want to be able to help many, 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 many more people. I think I want to be mindful of time, and I think we've covered a lot of ground this evening, talking about women and how it relates to lung cancer. One of the things we haven't talked about, really even outside of lung cancer and just in general, is how powerful the voice of the woman is. We tend to be the caretakers and the ones sort of taking charge and spearheading, particularly when it comes to healthcare. So, what is your advice, Dr. Duma, to women out there and how they can get involved and use their voice to help advance really anything in lung cancer, whether it's patient education right down to research?
I think there is nothing more powerful than a woman. And this is not only related to lung cancer, but my spleen as a daughter of a female surgeon in the 80s. But I think the woman voice is strong because we are changing the face of lung cancer. And this extends to the work of Bunny. I couldn't be here if the 2 patient advocates that you may know called Jill and Ivy hadn't adopted me when I was a resident. That is a few years ago, in which I came to these 2 amazing women and I told them, I think lung cancer is different in women. And the two of them were like, yes, let's do that. It's so different. Right. And they're now my investigators in the SHOW study. The study was designed with the input of Jill and Ivy, and it couldn't be around, like it couldn't exist without those 2. And women are changing how we do this. And I think I want to use this space to empower my patients and any other patient or caregiver that your voice really matters. When a patient meets another patient, you can connect, offer peer-to-peer support, a support I cannot offer as an oncologist. I cannot even touch the surface of understanding what you're going through. So supporting each other and being a voice for something that matters to you carries a long way. And I don't think lung cancer advocacy would have existed how it exists today without all these women.
I think a lung panel here in the living room, as soon as COVID's over, please, please, please be over soon. and where we're going back to normal, and we get these girls lined up, and you're the moderator, and Danielle and myself, and we just fire off the questions and, get the answers back. But, we've reached over 1 million people in 143 countries. We can get that female voice spread out, and it could be the beginning of something huge,
Mhm.
about really listening.
I agree. I agree.
It'd be exciting.
I think it would be fantastic. There is another question that came in, and I want to make sure to touch on it before we have some closing remarks. If you have nodules in your lung and start taking osteoporosis medication, does that increase the size of the nodules? And are there certain drugs for osteoporosis that are safer than others, to the best of your knowledge?
There have
And it's
been
another
no
thing that I think
direct.
osteoporosis. Go ahead.
No, sorry, go ahead. I thought you were done. My bad.
No, I was
There's the
I
delay.
was just going to say
Doesn't
that
let me know the delay
osteoporosis
because
is.
I don't know when the call is now.
I was just going to say that osteoporosis is another thing that women suffer with, and it's not really talked about that often. So please.
There is no relationship between the osteoporosis and risk of lung cancer. What I have noticed is that some of my patients that have osteoporosis sometimes get a fracture because they fall, and that's when a nodule is found. So it's like an incidental finding, right?
Yeah.
There's common falls. There is no association, to my knowledge, today, October 20th or 2020. But there is no evidence there. But if the patient has lung cancer and it has bone metastasis, it means the cancer went to the bone. And so, in circumstances, some patients benefit from those drugs to decrease the risk of further fractures. But about the nodules growing, there is no data that I'm aware of today.
And so with that, before I give my closing remarks, I will, of course, go to you to see if there's any final thoughts you want to share with those out there watching. And Dr. Duma, we'll start with you.
I think I would invite everybody to participate in the Schultz study because we need to define the problem to fix the problem. And sexual health is not only about intercourse, it's about intimacy, it's about kissing, it's about hugging, but many other aspects of sexual health that the study we ask you is not about how much intercourse are you having, because sexual health goes beyond that. And additionally, all questions are extremely confidential. You won't the survey and the register are no link, so there won't be direct. I won't get no data about personal information. And I think it's time that we put power in sexual health and women with lung cancer.
Exactly.
Absolutely.
I'm excited. I'm sure Danielle was going to let me talk in just a second. But I'm really excited about this. I'm really, really, really excited. Almost to the point of tears. We need to take these people out of the dark and put them in the light, and you know help them. And so much of this is because lung cancer has this stigma. And I really believe everything we're talking about tonight is going to make a huge difference in that, and in the health and the lives of all of these patients. I'm just really excited to really get moving, with the Shawl study and even our epidemiology study, because even though it's not just about young people, but it's about women and men, we're going to learn some things there too. And we're going to keep this going, right? We're going to keep this movement going.
Yeah, I couldn't agree more. And it's no accident that we're having this conversation during our October living room, given that October is Women's Health Month. I mean, it's typically known as, Breast Cancer Awareness Month, but it's a Women's Health Month, time for all of us to shine. And I think this topic has been so under discussed, if that's even a word, and just not shared. And so I'm excited that we started the conversation here tonight. I by no means think we've finished the conversation, because I think there's a lot more to talk about. And there's nothing like an empowered woman or women, the two of you, to get the ball rolling on this. And I can't thank either of you enough for coming out and, like I said, beginning this conversation. It's all too important, and it's about time. And I hope I get lots of emails and questions about the Shaw study and about some other things that we've talked about tonight. So thank you both so much. We are right at the 1 hour mark, so I'm going to close out with some housekeeping and some final thank yous. So, as most of you know, our fall events have all gone to virtual events, and our last 5K will be in Hollywood, Florida this weekend on 10/24. So, if you or anyone you know is out in the South Florida area, please be sure to reach out, and we can give you information on how to participate virtually. I've said before, our new program that our amazing events team started called My Perfect Marathon, launched in August for people who want to customize their own running experience. Since you can't actually participate live in marathons this year and or use the bibs that you may have received from us, we have set up this great program that allow you to do something this year and still, honor your bib for next year and or whenever those marathons come back into play. So please check us out for that too. Our annual gala is taking place on November 14th. It is a virtual event. If you have not seen the teaser for it, please check out our social media and our website. It's pretty great, and we have an evening. I think it's 45 to 60 minutes. I think it's 45 minutes, so it's not a long event, but it promises to be really fun and exciting. And there's still lots of, there's the raffle still on, and it's going to be a great event. You still get to dress up however you want. Yeah. For the latest news in our most recent joint statement on COVID and lung cancer, obviously you can find that on our website. And all of these things you can find on our website at lungcancer at gotofoundation.org or www.gotofoundation.org. And our registry, last but most definitely not least, and really at the heart of a lot of the things that we were covering tonight, please consider joining our registry and the Shaw study. And you can find that at lungcancerregistry.com. Thank you again to Dr. Duma for coming out this evening. I know you're in a whole different time zone than us. I hope you were able to get a bite to eat before we started this. If not, I hope you have something to eat for after. Thank you for coming out and chatting. This was a great girls talk. I mean, that's kind of how I feel this went, and there's nothing better than girls talk. So thank you both. All of you watching live and or post live, huge thank you to Peninsula Television, who's on the other end of this broadcast, still helping us virtually. And of course, our sponsors. Without their support, we would not be able to bring this to you. So there's Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Jazz Pharmaceuticals, Lilly, Merck, Novartis, and Takeda. All of them see the value in bringing this information to you on a monthly basis and continuing to try to educate and empower, because as Bonnie always says, we firmly believe that educated and empowered patients do better. So thank you again, everyone, for coming out with us tonight, and we'll see you guys soon.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. be family. Just wait and see.